The TMJ TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Welcome, TMD warriors. It's Tuesday again, and we are here for the next episode of TMD Demystified. My name is Tony Urbanek. Today, we are going to discuss fact-checking about TMD TMJ as it relates to neuroleptic drugs. In other words, what is the truth and what are the falsehoods regarding the use of neuroleptic drugs for the treatment of TMD? So in my usual fashion, we'll get right into it. What is the definition of neuroleptic drug? According to the dictionary, a neuroleptic drug is any drug that tends to reduce nervous tension by depressing nerve functions. There are several categories of neuroleptic drugs, actually many categories, but these include two major primary categories: benzodiazepines, which would include the well-known drugs Xanax, Librium, Valium, Klonopin, and Serax, trade names, and SSRIs, which would include Celexa, Lexapro, Prozac, Luvox, Paxil, and Zoloft. Benzodiazepines and SSRIs are the two most commonly prescribed categories of neuroleptic drugs in the USA. Other categories would include drugs used as mood stabilizers, antipsychotics, and antidepressants. Now, in my experience, and I have, again, 50 years, one way or another, of treating patients with TMD, 36 years of interfacing with patients treating TMD surgically, and the last 14 years or so interfacing, diagnosing, treat patients with TMD to treat them non-surgically. Again, as I said many times, I added it up. I've interfaced, done consultations with somewhere around 10,000 TMD patients in my entire career. So I have to say I know something about dealing with patients who have these TMD symptoms. Along the way, I think I've seen patients use and been abused by many, many, many different kinds of drugs used to treat their TMD symptoms. As it works out, just yesterday, because I think most of you know who watch routinely, that I still see TMD patients once a week on Monday, and I record these episodes every Tuesday. As it works out, I saw a patient yesterday with TMD with a long history of use of antidepressants, literally a 25-year use of antidepressants and significant side effects associated with those antidepressants. I'll get into that maybe in a little bit. Significant negative side effects associated with antidepressants. So, but there is this large body of theories and a large number of doctors, both in private practice and in university environments, that insist on using neuroleptics of one kind or another for the treatment of TMD. So let's see if we can discuss this rationally and figure out why they're doing that, what their theory is behind doing that, and then we'll talk about what the actual facts are about neuroleptics in the use of TMD. So here's how the theory goes regarding drugs for the treatment of TMD. Drugs, well, let me just add, I've seen all drugs, which includes, I've seen many patients who have become addicted to narcotics of one variety or another because they've been supported with narcotics because of the terrible symptoms, painful symptoms associated with TMD. I haven't seen one of those recently as the country has come down on the use of chronic, constant narcotics for various reasons, and that's a good thing. But the point is, even to the point of addiction, I have seen many people addicted to drugs, and it doesn't have to be narcotic drugs, opioids. You can easily get to be addicted to neuroleptic drugs with significant side effects when you try to get off of them. In any case, the theory behind using drugs is the following. It is well established, well known, well agreed upon that people who are anxious, worried, stressed, are prone to bruxing. Clenching or grinding. Bruxing is either clenching and or grinding, can be at night, can be at day, it can be night and day. But bruxism is clenching or grinding the teeth, for which we do not understand the mechanism for bruxing. I think I've mentioned that many times in earlier episodes. We do not understand the mechanism for bruxing as it relates to anxiety, stress. We don't understand how anxiety and stress and worry modulates within the central nervous system to create this effect of uncontrolled clenching and or grinding. But we know it occurs. So we'll just leave it at that. The rest of that is just theory. We have theories about it. We know it happens in the central nervous system for sure. It is most likely happening in the brain stem, in the lower levels of the brain, but it is all theory. So we don't know. There is no fact that we can throw at this. All we know is it is agreed upon intuitively, and I would agree to, intuitively we know that stress, anxiety, and worry brings on bruxism. And actually, the statistics show that it's extremely common. Half the population clenches or grinds, bruxes their teeth at one time or another in their life. Most of them are not aware they're doing it. Not everybody turns bruxism into temporomandibular joint disease. That is for sure too, but a large portion of them do. But the theory is because anxiety, worry, and stress brings on bruxism, and bruxism is the number one, the most common cause of damage to the temporomandibular joint, continuous, never-ending motion and forces on the temporomandibular joint, that that stress, worry, and anxiety is related to and causes temporomandibular joint disease. And it is one of the causes, along with the other two causes, which are acute trauma of various kinds, automobile accidents, 4x4s off the back of the pickup truck, bar fights. You go on and on about the different ways you can damage the temporomandibular joint in acute trauma, and then chronic trauma, which would include any type of functional malocclusion over a period of time. So those are the three main causes of damage to the temporomandibular joint, all creating chronic inflammation within the temporomandibular joint. But again, getting back to the theory is why some individuals and some university programs insist on using drugs is that there is a poorly defined relationship between fear, anxiety, and stress and bruxism. It is poorly defined. We can't say for sure. It is very common. It is even mentioned in several Bible verses. I'll quote one, Matthew 13:42, and will throw them into the furnace of fire. In that place, there will be weeping and gnashing of the teeth. So we've known for a long time, for a long, long time, that anxiety, worry, and problems, which would certainly be thrown into a furnace of fire, would bring on bruxism. Okay, so we've got that as a fact, okay? And so, as the theory goes, as the logic goes, if you want to call it logic, if you decrease anxiety, stress, and worry, then you should be able to decrease the bruxism. And so the dental doctors and the medical doctors have decided that prescribing neuroleptics, which by definition is any drug that tends to reduce nervous tension by depressing nerve functions. And we've gone over the different categories, and the two major categories as SSRIs and benzodiazepines. So if you prescribe some of these drugs, you will depress nerve functions, and therefore decrease bruxism, and therefore prescribing neuroleptic drugs is an appropriate method to treat TMD. So that's the theory behind it. That is the theory behind it. I can say from personal experience, I know of two major university dental schools whose very prominent and promoted TMD programs promote the use of neuroleptics for treatment of their patients. And a third particular very well-established, very well-known oral and maxillofacial surgery program, if you go into that program with the symptoms of TMD, you will automatically be given a neuroleptic drug as treatment of choice without any further discussion. If you have the symptoms, you are going to leave with a neuroleptic. So I mentioned before that I had a patient just yesterday who had a 25-year history of actually benzodiazepines for his anxiety, worry, stress, and he had a good case of tardive dyskinesia going on, unresolved, uncontrolled motion of the mouth, lips, trying to talk through all that. Tardive dyskinesia, which not only is a problem in itself, well-known, well-established by using long-term or even shorter-term neuroleptics, but besides the damage that bruxism can bring to the temporomandibular joint, constant motion of the jaw and lips will only exacerbate that motion within the temporomandibular joint and exacerbate the TMD symptoms, which are all centered around chronic inflammation in the joint. The more you move the joint, the more chronic inflammation. The more chronic inflammation, the more symptoms. That's the fact behind it all. So here are the known, well-accepted complications of using neuroleptics. These side effects, doctors give a drug and they give it for a reason, but they don't tell the patient at the time that you're going to be taking it for. The drugs are nothing more than a bunch of side effects. A drug has multiple side effects, and the doctor who prescribes them gives that drug for one of those side effects, which they would then call a primary effect, but you got to take all the side effects along with it.